Hi, my name is Nancy Sisk, and I'm the VAD educator at Ascension Seton Medical Center in Austin, Texas. And I assist the VAD coordinators at Ascension Seton Heart Specialty Care and Transplant Center. This presentation is a boil down of what you need to know for emergency care of an LVAD patient in the community. I will go over the devices, their specific equipment, including alarms, and highlight key assessment findings to help manage these wonderful patients. A VAD is a ventricular assist device for the failing left ventricle. It is an implanted mechanical heart pump that's used to treat heart failure after other therapies have been exhausted. Some of those failed therapies include medications, home IV inotropes, and biventricular pacemakers. The purpose of a VAD is to assist the heart by improving cardiac output to prevent additional organ failure, like the kidneys, liver, and brain. There are two classifications of patients that need a VAD. The first type is referred to as a bridge to transplant or a BTT patient. The second classification is referred to as a destination therapy or DT patient. These are patients that require permanent VAD support because they don't qualify for a heart transplant for reasons like age, BMI, or borderline kidney failure. The goal for this patient is to improve their quality of life and give them more time with their family to do the things they enjoy. Here are the types of VADs our patient population has implanted. We have at the bottom a hardware HVAD, but this device is no longer being implanted. We have the HeartMate 2, which is being phased out and replaced with the newest generation VAD, the HeartMate 3. These VADs are all LVADs, meaning they support the left side of the heart only. If a patient has right heart failure that needs mechanical support, they will remain in the hospital until they recover, get transplanted, or go elsewhere for a total mechanical heart. When you see a VAD patient in the community, you may not even know they have a VAD because they are very clever at disguising their equipment. In addition to the VAD equipment these patients are attached to, they should always have their backup equipment with them. No matter what, no exceptions. They may be in a purse or a backpack or some other type of bag. Backup equipment should include a backup controller to fully charged batteries and hopefully a tag with their implanting center and with their VAD coordinator's contact information. And if you're lucky, they will also have a list of their current medications. So please do not forget the patient's backup equipment when transporting them to the hospital. If their caregiver is present, bring them along too because they are very knowledgeable. Here is a side-by-side picture of a HeartMate and hardware HVAD patient so you can see what their VAD systems have in common. Both pumps are inserted into the apex of the left ventricle. The motor inside the pumps will pull blood continuously from the ventricle and propel it out of the aorta and into circulation. Again, the purpose is to improve cardiac output and prevent additional organ failure. Both have drive lines that exit the body and connect to a controller. A controller is basically a computer that operates the pump and connects it to power. In these cases, the patients are both using battery power. The controller also has alarms and indicators to tell how the patient and VAD system are doing. Looking at these setups, you can probably guess there are some lifestyle restrictions. There will be no swimming for these patients for obvious reasons. As far as showering, after the tissue around the driveline has healed, patients will use a shower bag to protect their equipment and themselves. Contact sports are prohibited related to the driveline potentially being pulled and because these patients are anticoagulated, so there's a bleeding risk. Before we get into VAD pump specifics, it's important to understand what causes a pulse. Blood volume in the ventricle creates pressure. During ventricular contraction, the pressure in the ventricle has to overcome aortic pressure in order to open the aortic valve and eject blood. The opening and enclosing of the valve creates a patient's pulse. When a VAD is placed, there are two concepts to understand. VADs are continuous flow devices, which pump blood throughout systole and diastole. When a VAD is placed and the pump speed is increased, the pulse pressure begins to narrow. This is because the blood volume is decreased and therefore pressure is decreased. If the ventricular pressure is lower than aortic pressure, the aortic valve will not open or it will only open intermittently. This is the reason that some VAD patients have a pulse and some do not. It depends on the amount of support the patient needs that's provided by the VAD. Now let's take a closer look at how each of these pumps work and how to take care of these wonderful patients that have them. First, I'm going to cover HeartMate devices. Despite the design difference, both pump motors contain magnets, and when electricity is applied, the motor spins to pull blood out of the ventricle. The faster the motor speed, the higher the flow of blood out of the ventricle and into circulation. Remember, flow is continuous, so depending on the degree of support, the patient may or may not have a pulse. The motor speed is determined based on the patient's need when the VAD is implanted. A key point to remember is that HeartMate 3 has a pulse mode that occurs every 2 seconds to prevent clot formation inside the pump. This does not generate an actual patient pulse, but you will hear it when assessing the patient. The driveline connects the VAD pump to the controller. For HeartMate 2, the driveline is a solid cable, and if there's any damage, it may or may not be repaired. In other words, depending on how bad the damage is, the VAD, meaning the whole entire pump it's connected to, may need to be replaced. Some of these patients have had their VADs for many years. VAD patients get really comfortable with their device and they forget it's there, so they get stuck in doorknobs, in car doors, or chewed on by pets. HeartMate 3 has an updated driveline design with a section that can be replaced if damaged to avoid surgery and pump replacement. You'll need to check that this connection is locked and that the yellow line is not visible. If it is, lock it. When prepping a patient for transport, make sure the driveline is secured to prevent pulling or tugging. Now for the HeartMate controller. One of the first things to check for is what we call the green circle of life. When it's illuminated, we know the pump is running, and it's one of the first things to check if an alarm is occurring. This is in addition to actually putting a stethoscope on the patient's chest and listening for the VAD pump hum. If an alarm does occur, here is the alarm silence button to help you think clearly and hear the VAD coordinators when they're trying to help you troubleshoot. Now I want to show you how to check the VAD numbers. This square button is called a display button. When pressed, it will scroll through screens to display information about the VAD. It's important to note that you cannot make changes to these numbers. You can only view them. The first number is the speed the VAD motor is spinning. It's measured in RPMs like your car. The speed sometimes fluctuates anywhere between 50 and 150 RPMs. Next is the flow that is generated by the motor spinning. It's measured in liters per minute. It's basically an estimated cardiac output based on pump speed, power, and blood viscosity. We like this number to be greater than 3 to be sure the patient is getting blood out for organ perfusion. Then there is PI. This number gives us an idea of how much the pump is assisting the patient. If the pump is doing more work, more blood is being pulled out of the ventricle, and this will cause the patient's pulse pressure to narrow, so the PI will be lower. If the pump does less work, less blood is being pulled from the ventricle, so it will fill and create pressure and exit the aortic valve. This will widen the pulse pressure and is usually associated with a higher PI. We like to see the PI range between 3 and 5. Power is needed to run the pump, and it's measured in watts. If the power is 2 watts above the patient's baseline, which they should know, or if it's greater than 10, there may be something wrong with the pump, or there may be an obstruction. This last screen shows the internal controller battery is charging or is charged. This unit does have an internal backup battery for absolute emergency loss of power to prevent the VAD from stopping. We say it's like an airbag. You know it's there, but we don't really want to use it. Occasionally, an intermittent alarm occurs and you may not catch it, or the VAD coordinator may ask you to access the alarm history. To do this, you press and release, kind of fast, the display and silence buttons to open the alarm history screen. You'll see the alarm, a timestamp of when it occurred, and how long it lasted. Press the display button again to see additional alarms. The HeartMate VAD is powered by either AC power or battery power. If the patient's at home and connected to AC power, they will need to be on battery power before being transported to the hospital. If the caregiver isn't there, you'll need to locate the battery clips inside the backup bag. Insert batteries and attach them one at a time. Batteries have a little fuel gauge on here. Each bar represents 20% of power. This one has only 60. Depending on the age of the batteries, a pair typically lasts 10 to 12 hours. You've got an arrow here, you snap those in. The most important thing is that when you disconnect, you're only gonna do one at a time. So it doesn't matter which one, both provide the same amount of power. So you are gonna unscrew this little retaining screw, pull straight back, and it's going to chirp, and it's going to tell you connect power. So you have a half moon here and a half moon here. You want to connect it to make a full moon. You can kind of feel it engage. You don't want to be forceful because you don't want to bend pins. Once you feel it engage, you're going to push it straight in, and then you're going to just tighten this little screw right here or this little sleeve until it stops. You don't want to over tighten it so that you don't strip it. If while you are transporting the patient and a yellow diamond alarm occurs with the message low battery, replace power, you can get a pair of batteries from their backup bag. Press the battery clip release button to remove the low batteries one at a time and snap in the new batteries. If you don't change the batteries when the yellow alarm occurs, an annoying red battery will alarm. It doesn't matter how much time you have, please change the batteries when it indicates to do so. If the red battery alarm is ignored, a continuous, loud, irritating alarm will sound and more lights and a demonstrative message indicating the backup battery is now in use and to connect power immediately. After this alarm occurs, the pump speed will begin to decrease in order to conserve power. Remember, the backup battery is like an airbag. We know it's there, but we don't want to use it. It's for emergency purposes only. So, as soon as the yellow diamond alarm occurs, change the batteries one at a time. Now let's look at some other alarms. The first thing to do when an alarm occurs is assess the patient, listening for a pump hum in the left upper quadrant. Next, make sure the green circle of life is illuminated. Silence the alarm, read the displayed message, and call the VAD coordinator. A red heart alarm has a few causes. The most common red heart alarm cause is low flow. It's hot in Texas, and VAD patients are used to heart failure fluid restrictions, and they get dehydrated. Other causes might be medication related, such as blood pressure medications or Lasix, or they may have blood loss related to GI bleed. Another rare but possible cause of a red heart alarm is a disconnected driveline. If this happens, the green circle of life will not be illuminated. A connect driveline and contact hospital will display. If the driveline disconnected during transport, connect it. Remember that HeartMate 3 has 2 connection points. If the connections are secure, check for damage. If the driveline was disconnected before you arrive and the patient is tolerating, call the VAD coordinator immediately. If the patient is not tolerating either of these red heart alarms, CPR or defibrillation may be needed. Again, the VAD coordinator must be called to assist with troubleshooting and patient management. Seen less often is a yellow wrench alarm with a message to contact the hospital. It is associated with a controller or driveline problem, and the VAD coordinator will assist you with what to do. This is not a life-threatening alarm. Remember, if the green circle of life is illuminated, the pump is still running, and you can confirm this by auscultating. Now let's look at the Heartwear HVAD pump. We still have quite a few patients in the community with this VAD, and people travel with it, so it's important to review. Remember, this VAD also pulls blood continuously from the left ventricle to the aorta, and the patients may or may not have a pulse, depending on the degree of failure they had when it was implanted. The more support the pump provides, the less pulsatile the patient will be. Connecting the HVAD pump to the controller is a driveline which is inserted here. Like the HeartMate driveline, it's important to check it is secured before transport to prevent tugging and pulling. When the HVAD pump is running, the VAD numbers will always be displaying speed in RPMs, flow in liters per minute, and power in watts. If an alarm occurs, the triangle here will illuminate with a message on the screen. For battery-related alarms, change the batteries. For other alarms like controller fault, high watts, low flow, call the VAD coordinator. If they ask for the VAD numbers while the alarm is occurring, press this arrow down button and the VAD numbers will reappear. If any alarm is not being tolerated, defibrillation and/or CPR may be necessary. The hardware HVAD has extremely loud alarms if the condition is a high priority, meaning potentially life-threatening. So here is where the alarm silence button is located, so you can focus and hear the VAD coordinators when they are trying to help you troubleshoot. Remember, assess your patient first. The power sources for hardware HVAD are similar to HeartMate, AC power and battery. Let's look at the differences between them. If you are transporting a patient from home, they may be connected to AC power, which looks like this. It's just a plug into the wall. And you see they are connected to a battery. There are indicator lights to show the power source in use. When the AC power cable is disconnected to attach a battery, the controller will auto-flip to the already connected battery. If the patient is already on battery power and a battery alarm occurs, the controller will tell you which battery to change first, battery 1 or battery 2. Just follow the controller's instructions. Hardware HVAD batteries also have a fuel gauge. Each bar represents 25% power. These patients also need to have their backup equipment with them at all times. This includes an extra HVAD controller and 2 fully charged batteries. Now that we talked about the devices, let's get a little more specific about what to do when you arrive on the scene. First, you want to identify the device. If the patient or caregiver aren't present to tell you, look at the controller. No exceptions, all VAD patients must have their backup equipment with them at all times. At minimum, this includes a backup controller and 2 fully charged batteries. If there are any issues, call the VAD coordinator. The first rule of thumb for all VADs is to look at the patient first and then the VAD. When assessing a VAD patient's heart tones, you will hear a hum loudest over the left upper quadrant. Depending on how much the VAD is assisting, the patient may or may not have an S1, S2. If they have a HeartMate 3, you will hear the pulse mode. This function is to keep the pump clear of clots, as mentioned earlier. When assessing a VAD patient's pulse, it may be intermittent or just plain difficult to obtain. You'll probably need a Doppler. The HeartMate 3 pulse mode that occurs every 2 seconds can make it even more challenging to figure out. Just don't confuse it with an actual patient pulse. If you are unable to palpate a pulse, or if the pulse is intermittent, check the pulse for 1 minute. A Doppler map will need to be obtained using a manual cuff and a Doppler over the radial or arterial artery. As the cuff pressure is gradually reduced, the first crock cough sound signifies the map. To obtain a pressure, assess the patient's pulsatility. If the pulse is palpable, a manual cuff can be used with a stethoscope and a map calculated by adding the systolic pressure to 2 times the diastolic pressure and dividing that by 3. It will be important to communicate this pressure with the VAD coordinator, and especially if the map is greater than 90. An auto cuff is not used because they have not proven to give consistent, reliable results and may only be accurate 50% of the time. An O2 sat probe may or may not give a good reading if the patient's pulse pressure is narrow. You can try placing it on the ear or on the forehead, but if those methods don't work, you'll have to rely on your good assessment skills. Are they mentating? Are they pink, warm, and dry? Do they have good capillary refill? And of course, assess their respiratory pattern and rate. If a 12-lead EKG is necessary, V5 and V6 can be removed because they sit over the pump, and that may cause interference. As for ACLS, defibrillation is okay. Pad placement should be on the front and the back and not over the pump. Do chest compressions if the patient is not breathing and a pulse or VAD flow is undetectable. Don't forget to check the pump sounds, and remember the VAD coordinator will be available to assist you. The most common VAD problem and alarm we reviewed in this video is the low flow alarm related to hypovolemia. Other common problems that you may see include hypotension, hypertension, stroke, bleeding, electrolyte imbalance, and driveline infection. These patients and their caregivers are amazing. Please use them to help with equipment management. If possible, allow the caregiver to accompany the patient to the hospital. Always assess the patient first and the device second. If an alarm occurs, read the instructions on the controller and call the VAD coordinator. And now I'm going to end with one of my favorite quotes. If plan A didn't work, the alphabet has 25 more letters. Stay cool.